Thank you. Well, thank you so much for hosting me today. It's a wonderful initiative. I graduated at the class of 2018, I think it was. I went to a few TMS and tDCS workshops when it was at UCL in person, and it was a wonderful experience and a really nice, and I still stay in touch with the people who I met there. So hopefully the check is in the post for Brainbox Initiative there. The other thing I wanted to say is that this will be the last time I give this talk. So it's been sort of on tour at different conferences, and I thought a natural place to retire it would be for such a really enriching initiative. So I'm really happy to be here today. So I'm going to walk you through a few years worth of work while I was a postdoc at King's College London, and a few pieces of work since then. And I want to try to have it so that everybody walks away with something. So I expect people will be brain stimulation experts or experts in ADHD, but probably not both. So hopefully I'll be speaking to those two types of people. So I'll just give you an overview of ADHD and how it's treated, and then what alternatives there are, and then walk you through an RCT that I led on and what the future directions can be, and then I'll take questions. So ADHD, we've known about ADHD for centuries now, although we probably wouldn't have called it ADHD as we would call it now, or indeed recognize it as we would recognize it now. But if you look back at the literature, you can see in particularly German children's books, there were certain characters that had the sort of hallmarks of ADHD. Heinrich Hoffmann most notably published a piece in the mid-1800s called Fidgety Phil. And Fidgety Phil often fell off his chair and was sort of always getting up out of his seat and constantly squirming. And then you had Johnny Look in the Air, and here he is, Johnny's walking along, and he's so distracted by what's going on in his environment that he falls into the local canal. So those are, I guess, stereotypical views of hyperactivity, impulsivity, and sort of inattentiveness. Then bringing us into the sort of modern day, there's a short timeline here of key moments in the sort of history of ADHD. I won't dwell too much on each of them, but it's just a nice sort of historical context for those interested in ADHD. So we have George Still, who sort of was the sort of founder of modern pediatrics, and he called it a sort of disorder of moral control, which is one of those turns of phrase that are sort of designated that part of the turn of the century where everyone was sort of Victorian and very prudish and very much concerned with morality. And then sort of 1940s, 60s came along, and it was sort of considered a minimal brain disorder or dysfunction, and that actually come under quite a lot of fire during the time, as well as, you know, retrospectively, because it really didn't quite capture, and it's quite too vague, and it was also quite stigmatizing, and we live with some of that stigmatism today. And then in the 60s, we get the first drug for ADHD. So I won't bore you with the full story of this, but the great story behind the most commonly used drug, methylphenidate, is that I think it was a Swiss chemist was sort of cooking stuff up in his lab, and he was mainly interested in blood pressure, and he used to play tennis with his wife, and she had blood pressure issues, and so he gave her this drug, and she quickly started thrashing him at tennis. And like all men of that age, and probably some today, he thought that this could not be possible. A woman can't beat me at tennis. And then when he sort of quizzed her about it, she described feeling that she had sort of tunnel vision, and she could focus more, and she had more energy to sort of persist and be concentrated. And he thought, oh, well, this might be useful. So it was sort of used not only as a sort of antidepressive sort of blood pressure tablet, it could be used in psychiatry. And as an ode to his wife, he called it after her, and her name was Rita. So that's why we call it Ritalin. And it is perhaps the most effective drug in psychiatry. It's remarkably effective. And then during the 70s, we get the sort of codification of psychiatric or mental health disorders, and ADHD makes an appearance in one of the early versions of the DSM, I think the third iteration. So DSM-5 categorizes ADHD as a sort of persisting, impairing symptoms that are age inappropriate. And these can sort of center around or characterized by sort of inattentiveness or impulsivity and hyperactivity. But we know now, thanks to many decades of research, that ADHD is also associated with cognitive impairments as well, particularly in executive functions such as sustained attention, motor inhibition, and so on. And to give you a flavor of what it would be like to live with ADHD and to have it, I've got this video, and I've been reliably is shocking, but I'm going to play it anyway. That Rory Bremner did, because Rory Bremner, the famous sort of satirical comedian, British comedian, he has ADHD, and he sort of did this documentary, and my former supervisor makes an appearance there. So do have a look at it on all your reputable pirate websites. So yeah, so basically we have ADHD. We know the sort of constellation of symptoms, issues with sustained attention. So children might mind wander, they might get distracted easily, they might squirm in their chair, they might sort of call out in class, and so on. And historically, we used to refer to these different forms of ADHD as sort of subtypes, but now we call them presentations, because we know now that the symptom profile is not stable over time, and certain even contexts, children can exhibit sort of symptoms to varying degrees and in different sort of qualitative differences. It's one of, if not the most diagnosed neurodevelopmental disorder in children and adolescents. And I've been speaking mainly from talking about ADHD as a neurodevelopmental disorder, but we now know in recent years that the disorder can continue and persist into adulthood, but also it can actually start in adulthood as well. So as a lecturer, I see it all the time, where somebody who's never presented with ADHD at all, when they join university, everything's a lot more challenging and they fall behind, and it's because they have a form of ADHD which only presents itself with the increased workload at university. There's an interesting gender difference, which I always like to bring up in these sort of talks, and it's far more common in boys, sort of a 2-to-1 ratio in boys in childhood, but that sort of shrinks in adulthood. And there's all sorts of theories why this may be, but the popular one, I guess you could call it, is that more often than not, the person who identifies a child as having ADHD is the teacher. And in the UK context, often one teacher is with a class of 30 students, and you will therefore be more likely to see disruptive behaviours, and those are usually exhibited by boys. So they're more hyperactive, they get up out of their chair. You'll be less likely to see inattentive behaviours like looking out the window and being distracted, and those are behaviours exhibited typically by girls. In adulthood, the reason why it might narrow is that men are notoriously very bad at seeking support from their GP or a counsellor, and so they kind of drop off, whereas women are exemplary. They do seek out help and support wherever they can. So there seems to be a sort of shifting of the scales there. ADHD is very expensive. It's associated with all sorts of direct and indirect costs, direct being sort of in terms of medication use, but also the burden on health service, but also indirect costs, societal issues. It's associated with increased crime and substance misuse and so on. So it's a real issue. And I mentioned before that the methylphenidate is the gold standard, and it's a very, very effective drug. It's so effective that about 70% of at least children respond to it who have ADHD, and they see a reduction in symptoms. So it's a very, it's like a rare actual thing that is really does work in psychiatry. The only problem is that it's associated with quite bad side effects, disrupted sleep, loss of appetite, stunted growth as well. It's not indicated for everybody. As I've said, about 30% don't respond to it. As children get older, they tend to adhere to their regime less, and this is just because it's not very nice when you can't eat out with friends, or there's all sorts of stigmatism around that. And the other issue is that the long-term efficacy has not been fully indicated. So the evidence from longitudinal studies show that it's probably only effective anywhere between 3 to 5 to 7 years. So the hunt is on really for alternative treatments, and there's been all sorts of research looking at sort of behavioural therapies, CBT, and also dietary supplements, but they all show kind of small to moderate effect sizes. So this throat clearing that I've given is sort of to move towards my work and what I do. And so I'm sort of quite interested in sort of non-pharmacological interventions for ADHD individuals. And I'm currently doing a meta-analysis, which is gradually killing me, that is trying to quantify definitively the effect of cognitive training on ADHD. I won't give any spoilers, but I wouldn't bother wasting your time or money on it. Then there's also other forms of neuromodulation techniques. So historically, EEG neurofeedback has been used a lot in ADHD, and it does come with some limitations. And these are trying to be met head-on with fMRI neurofeadback, which can contact deeper brains and be far more spatially focal. And colleagues of mine at King's are submitting or revising a paper which shows a sort of RCT reporting on the effects of that, but I'm not at liberty to give you the results of that. So moving now on to brain-based therapies. So I've touched on neuromodulation, but I just want to do a deeper dive of why brain-based therapies might work. So what is interesting is that ADHD is, I think I'm right in saying that, is probably the most scanned brain in cognitive neuroscience. So we know a lot, in other words. I mean, you could, well, the phrase I always like is, we know more and more about less and less, or the other way around, I think. So we know a lot, but there's still a lot to be learned. But what we've learned so far is that one area in particular seems to be sort of associated with ADHD, and that's the right inferior frontal cortex. You see that it's dysfunctional. Its dysfunction is associated with ADHD symptoms such as impulsiveness and inattention. And there's also underactivation during cognitive control tasks, so motor inhibition, interference inhibition, and switching. And my former supervisor, Katia Rubio, has really contributed a lot to the field to sort of show this evidence. The other thing as well is that in acute and chronic stimulant use, you see that the right IFC is actually upregulated. So that might give a sort of sight at, or sort of a mechanism of action of why psycho-stimulants such as methylphenidate are so effective. Maybe it could increase the activity of the right IFC. And the right IFC, it sits in a network hub of sort of cognitive control, attention, inhibition. And Russell Poldrack's work and Aaron have sort of shown that it's really important for inhibitory control. So to sum up, right efficacy seems to be associated with the clinical and neurocognitive impairments in ADHD, and it could be a target for a mechanism of stimulant medication. So now on to my work. So I work with tDCS, and this is probably one of the most horrendous slides you can give at a group of people who are experts in tDCS or brain stimulation. But often tDCS is conceptualized along this sort of simplistic lines, and unfortunately that conceptualization was still kind of regarded with some esteem when we started the trial, so just bear with me, please. But the idea is that you have two electrodes, and you inject a very weak electric current of 1 or 2 milliamps, and the current flows from one electrode to the other, from the anode to the cathode, and it goes through the path of least resistance, some of which is through the brain. And it's thought that it can produce a net increase in cortical excitability under or around the anode, and a net decrease in excitability under and around the cathode. So the sort of extension, this sort of sliding scale conceptualization is that you increase activity, you can improve the function of that region in the same way that we say that an increased activity in neuroimaging shows that this area is associated with this particular task or function. So I'm going to move on. There's all sorts of kind of advantages of using tDCS, particularly in pediatric samples such as ADHD. And I guess you could compare this with its older sister, TMS. TMS does require a lot more training. It's less user-friendly. It's more costly as well than tDCS. And from if you want to get a child with ADHD to sit down in the chair to be administered TMS, well, to find a child like that is sort of trying to find hen's teeth. So the other advantages of tDCS, like TMS, is that it is thought to at least modulate cortical excitability, and this could then lead on to long-term potentiation and long-term depression. It's unclear how long the long-term effects are, but it has been seen after stimulation. And there's ways that you could potentially optimize the effect of stimulation. So you could, for example, administer it over multiple sessions, and you could even combine it with cognitive training. And the idea is that you could functionally prime areas and have this sort of synergistic effect with tDCS and cognitive training combined. The other good thing about tDCS, before I move on, is that it is well tolerated, and also it's been shown to enhance the release of dopamine. And a key component of methylphenidate is that it increases the abundance of dopamine in the system. So there's an overlap in a potential mechanism of action for how tDCS could improve cognition and symptoms in ADHD. So does tDCS work in ADHD? This was the first meta-analysis published back in, I think, 2020 or 2019, and a lot has changed since then. But it was the first to sort of demonstrate encouraging findings. They found sort of on inhibitory control measures that anodal tDCS, so excitatory tDCS over the dorsolateral prefrontal cortex, can improve sort of inhibitory control measures and overall on accuracy, and also in working memory in terms of sort of reaction times and time for completion. I do have, and I'm not ashamed, afraid to say this, I do have a lot of misgivings about this particular meta-analysis. I don't want to get, into the weeds about making a statistical opinion, but there's certain things you shouldn't do in a meta-analysis, and one is to break the assumption of independence, because that can inflate the chances of getting a significant result. So they had multiple dependent effects there. And they, in their analysis of inhibitory control and measures, so task measures of inhibitory control rather than behavioral symptoms, I should make that clear. These are just task measures, not symptoms. In the analysis of inhibitory control measures, they included non-inhibitory control measures. So it completely conflated measures of attention as well, and just processing speed. So it's actually unclear what's going on here. I mean, a fairer sort of interpretation of this is that it sort of improved generally executive functions. There was also statistical reporting errors as well, but they did issue a correction to those errors. So just look out for that other version of the paper before you sort of cite the exact numbers. My team and I published a meta-analysis soon after, and we addressed some of the limitations that I previously described in that previous meta-analysis, and we were able to get, at the time, 14 studies to be meta-analysed, and we could only get data from neurocognitive measures. So overall, most of the studies targeted the dorsolateral prefrontal cortex, mainly in children, and we found there was no effect on the measures of attention, no effect on measures of inhibition, and no effect on the measures of processing speed. The way that we interpret this is that perhaps because it was sort of unpowered, it could be a sort of a trend for these, but I didn't like to write that, but for balance we did, and I think it's been subsequently proven that I was right in the end. So I just want that on record. An issue with the studies is that they do have quite a few issues with sort of risks of bias as well, particularly with selective reporting. So a lot of the studies, we found that they, analyzed non-significant interactions, or they, only sort of fished through certain outcomes, but not others. They didn't correct for multiple testing. All these kinds of issues that we found were a bit dodgy, which is why we kind of squared the fact with a lot of these studies actually reporting statistically significant results, but when you aggregate them in a meta-analysis, they kind of all go away. So one of the issues with the studies that I didn't mention is that most of them they're very heterogeneous overall, basically. So they've got issues with different study designs, outcome measures, they're just horrendous. And they mainly target the left dorsolateral prefrontal cortex, which hopefully by now you know might not be the appropriate site given the wealth of evidence and the strength of evidence supporting the right IFC as a good place to start. And at the time, only 2 studies applied tDCS over multiple sessions. I just want to sort of quickly plug a couple of things here. One is that I did a review with Katia Rubia and a few others, and we looked at EEG neurofeedback as well as tDCS. So it's a kind of update, and we kind of found the same picture a couple of years later. And then I'm very fortunate enough to be working with a team at King's led by a really talented PhD student, Lucy Gallup. And we're currently in the stages of sort of submitting a systematic review looking at the effects of tDCS in children and young people with psychiatric disorders. And I think Lucy's in the audience, so I just want to say I will make the corrections to the paper and send to you as soon as I can. I'll do it after the talk, hopefully. And what's interesting, I won't tell you too much about this, but what is interesting is that at the moment it seems that the direction of traffic in the field is heading in a generally positive direction with larger samples and and more comprehensive outcomes. And a point I always make as a joke is that it seems that the number of reviews and meta-analyses are outnumbering the number of actual studies there are. So if anybody wants to do one, I would advise against it. It's becoming a crowded, saturated market. Okay, so I've said to you that basically the study at the time, when we first started this RCT, which is sort of 2016, 17, the evidence wasn't great, but there was lots of limitations with the study. So we put together this project, and it was going to use multi-session tDCS applied over 3 weeks. We were targeting the right IFC, and we're combining it with cognitive training of lots of executive functions. And one of the reasons why is because an early meta-analysis showed that if you target multiple processes at once, you might have a sort of, it's almost like throwing the kitchen sink at it, you might get a larger effect. It was a randomized control trial, and it had a sham control, and it was a parallel study with 26 in one group and 24 in the other. The unevenness was just simple case of how the randomization worked. It was done independently. And it was also pre-registered, which is something that a lot of the studies are not. And at the time, we thought we were adequately powered to get a sort of clinically meaningful effect with 50 participants. So this is what it looked like from a sort of bird's eye perspective. We had a sort of pre-screening where we confirmed a diagnosis of ADHD ourselves. They could not have an ADHD diagnosis, like they could be on a waiting list, but most of them did have a clinical diagnosis, and we just confirmed it. We did a bunch of clinical rating measures, so from parents and so mainly from parents. And we also did a cognitive task battery as well, measuring all sorts of cognitive functions, sustained attention, inhibition, working memory. And we also measured EEG as well. And we did those same measures before, after, and then 6 months later. In terms of the brain stimulation, it was Monday to Friday for 3 weeks, and it was in sort of 20-minute period of stimulation. And during that time, they played video games. The difference in the games differed. So on Mondays, Wednesdays, and Fridays, they did sort of multiple process training. On Tuesdays and Thursdays, they did the same, but we also put in our own sort of stop signal task to sort of really train motor inhibition. Okay, so this is what the games look like. And hopefully this is better.
Hello there, I'm Captain Bluefeathers, and this is our ship, and we could use your help. Some local monkeys from the...
So you can see this is an example of one of the games. Hopefully you can see this. So you have, this is called the magic lens, and you have target monkeys, the white monkey, and then you have distractor monkeys. And the participant has to press them as fast as they can. And obviously sometimes the distractor monkey is there, so they have to withhold their response. And the game dynamically adjusts so that as the children get better, the tasks become harder and harder. And so it's always keeping them at their full potential, which has been known to sort of elongate the effect of cognitive training in ADHD. So yeah, and you can obviously, it's been sort of designed to be really, engaging for children.
Every time we set up camp, the same thing.
Okay, I think that's enough of that. Right, so
hello there.
Oh, go away. Just a quick shout out to the Israeli team who put together. Well, they're a small company in a sphere that designed ADHD sort of relevant and exclusively sort of headgear for tDCS to be applied in children with ADHD. And for the people who like these sort of things, this is a sort of brush electrode where you dip this into sort of saline solution, salty water, and the saline is suspended in the fibers. And the idea is that this will keep the saline solution in one place, as opposed to having a sponge where as soon as you put a rubber band on the head, it leaks everywhere. The final video I just wanted to show you is I made an appearance on BBC Click. Unfortunately, only my crotch was filmed, so it was a real disappointment when I was telling my mum that I was going to be on the BBC. So I'll show you this segment, which may contain a flash of below the waist. But the idea here is just to show you what it looks like, and also the sort of the nature of one of the cognitive training tasks as they are stimulated. So
electrical currents to stimulate my prefrontal cortex, I was put through my paces once again. Pirate. Monkey. Sorry, I'm really bashing the iPad. Sorry. It's definitely fun and games. I just hope it's doing me some good.
Okay, so you can see there kind of what it looks like. Anyway, so what did we find? That's what you all want to know. So to start off, we looked for baseline differences, and we did find a few baseline differences. So the anodal group, they were slightly younger than the sham group, and they presented with more sort of oppositional defiant disorder symptoms. They also showed that the anodal group were worse on sort of a sustained attention task and a time discrimination task, and also working memory. We also analysed gameplay after the study, and we found that the anodal group played one particular game above the others, but this had a sort of inconsequential effect. So it's just there for completeness. Inconsequential in the sense that it wasn't correlated with any sort of outcomes that we found. So first of all, we had a primary and secondary outcomes. So the primary outcome was performance on a motor inhibition task, go no go, and a continuous performance task, which is measures sustained attention, and we found no effects on those. We did find a significant group by time interaction for symptoms. So we found that both groups improved over time. So from baseline to post. I'm not explaining that particularly well. So actually, just as a side point, the way that we analysed the data was we ran an ANCOVA, and this was covariing for baseline performance and also medication status as well. And so what you're looking at here is the post and follow-up. So that's why there's no baseline, basically. So we found a significant group by time interaction, suggesting that although both groups showed a reduction in symptoms over time, the magnitude of that reduction was greater for the sham group as opposed to the anodal group. Reading other papers that have cited us, such as one by Roy Cohen-Kadosh, they said that there was a detrimental effect, but actually that's not strictly true. So we found that this difference in symptoms was only seen at post, it wasn't seen at follow-up. So whatever difference there was, it disappeared over time, over that 6 months period. So in terms of secondary outcome measures, we didn't find anything at all again, and this was looking at timing, sustained attention, the Wisconsin card sorting test, which measures cognitive flexibility, working memory, verbal fluency, and so on. I'm just checking time. We also looked at ADHD symptoms and related impairments. So we looked at sort of mind wandering and sort of irritability and just global impression of symptoms. And again, we found nothing. The only thing we did find was sort of at post only, there was a greater reduction in symptoms in sham compared to anodal, sort of reflecting the previous finding that was on the ADHD RS. But again, it was only at post treatment only. In terms of safety, so tDCS was well tolerated. Overall, only sort of the typical routine things you hear, like itching or tingling or burning. What we found was that the anodal group actually showed greater adverse effects at post-treatment, and this related to mainly mood and sleep and appetite. So they had a disruption in those. And we found that the blinding was successful, which I think is a huge achievement, given that there's issues around blinding in tDCS. In a separate paper, so we got that published in Psychological Medicine, and then we published a separate paper, and I'm very much indebted to my colleague Natalie, who you can see pictured here, who analysed all the EEG data and shares first authorship with me on a paper that we recently got published, I think on Christmas Day last year. And basically what we did is that we analysed group differences in different EEG frequency bands, alpha, theta, beta, across the whole duration of the measurement. And we found again, again, I'm not explaining myself particularly well. So during the measurement of EEG, the participants were first at rest, and then they performed a go-no-go task. So we found no effect during the rest period on any of the frequency bands. And again, we found no sort of effect during the go-no-go task. We did find something, but once you did multiple testing correction, it disappeared, which is sort of this note here. And we also looked at F8, because F8 was actually the site where we placed the anode electrode, and again, we didn't find anything. So completely nothing there, at least from a statistical perspective. So bringing it all together, so we conducted the first double-blind RCT using 15 sessions of stimulation over the right IFC. And we combining that with cognitive training in one of the largest samples with boys in ADHD in the tDCS literature. We found no improvement in symptoms and cognitive performance, except for what I've previously mentioned, where for ADHD-RS and Connors, they were lower for the sham compared to anodal at post only. And there were some adverse effects seen in the anodal group at post-treatment only. So these findings extend our meta-analyses, which I mentioned earlier, which showed limited evidence of cognitive or clinical effects in ADHD. And these studies were, again, sort of single or very few sessions of stimulation over mainly the dorsolateral prefrontal cortex. So the future directions, RCTs need to be larger, they need to be adequately powered, they really do need to be double-blinded. There's no reason why now that studies should be single-blinded, at least at the point of randomization. There needs to be greater effort into looking at the cognitive as well as the clinical symptoms of ADHD. One thing I will pick up on in this many reviews I've done now is that there is an issue with people not understanding that there is a difference between a cognitive and a clinical outcome. Clinical outcome is measuring the behavior of the person. Cognitive outcome is measuring the cognition of that person. And I've seen reviews and I've reviewed reviews now where those two things are conflated, and it's misleading and not helpful. So I'll get off my soapbox, but that really shouldn't be happening. And there are other forms of stimulation which this study and our meta-analysis cannot speak to, and also the reviews I've done. So it could be that tACS, so alternating current stimulation, or random noise stimulation, they could potentially be more effective. They are, I guess, biologically plausible because they're entraining sort of inherent oscillatory activity. And there's also an FDA approval recently for trigeminal nerve stimulation, and there's a sort of interest now in stimulating cranial nerves. But this is based on one study, and the person who published it has a conflict of interest in that they have they are the CEO of the company, or they were the medical informer of the company. They're basically associated with the company, is what I'm trying to say. So don't come at me with legalese. So just to wrap up, thank you so much. This wouldn't be possible without the many different collaborators who have helped me out. And yeah, so I'll take time for questions. We've got 15 minutes, so I'm going to stop my screen sharing. Where is everybody?
Super.
Great.
For that, Sam. An interesting look into the research, and also like an overview for like just healthy research in general. I think some really nice tips in there. 2 questions so far. We'll have a look at these. I'll do like a bit of a wrap up from us, and then if there's any questions kind of filter in as I'm talking, we can look at those as well. So the first question from Jasper. I hope this means more to you than it does to me. But was the stimulation simultan? Maybe that's similar to the psychotherapy.
I'm sorry, I don't understand that question.
No problem. Jasper, if you're still with us.
Please clarify.
Yeah, clarify the question. We'll take another look. And Samantha. So really interesting talk. Thank you. I'm currently working with a data set in which children with neurofibromatosis type 1 NF1, which is often comorbid with ADHD, underwent multiple sessions of working memory training combined with tDCS. There's very few existing studies of CT and/or tDCS in NF1. I'm wondering whether the review you mentioned looking at NIBS in young people with psychiatric disorders includes any evaluation of NF1. This might be a bit off topic, sorry. So yeah, take it away, Sam.
I won't say that I'm getting this from the review because it's not for me to say. It's still a work in progress, and I don't know whether Lucy's in the audience, like giving me daggers to because everything's kind of top secret nowadays, isn't it? But I am unaware of any study that has looked at this. They are quite comorbid, but most of the studies thus far, the general trend is that you focus on what the primary diagnosis is. So you recruit, those children with ADHD or ASD only. You very rarely, or you try to reduce the sort of comorbidities if possible, or if there are comorbidities, they generally are not the sort of competing with the primary diagnosis or contributing to the impairment. So you might, for example, get a child with ADHD and depression, but the primary diagnosis is ADHD. So because of that, as a starting point, it kind of informs who you recruit and what you design a study around. So the study that you describe seems to be quite one of maybe a new wave of studies which want to broaden the research into potential ADHD with comorbidities. So I wouldn't be surprised if you are working on a unique study, or there is just only 1 or 2 other studies out there. So sorry, that was a kind of a long-winded question to say I don't know, but yeah.
Thanks anyway. Jasper has popped his hand up. So I will try and enable the microphone. So if you're able to, then yeah, do feel free. Whilst that is happening, any look? Not connected to you. All right, Jasper, are you able to speak to us?
Can you hear me?
Yes, all good.
Thanks. I actually only accidentally pressed the button, but and now I can. I actually wanted to ask if the stimulation was simultaneous to the psychotherapy, but I think you clarified that later on.
Yes.
That it wasn't. It was just simultaneous to the SST task. But actually, I want to ask another question. Why did you choose the intensity for 1 milliampere, and why didn't you choose for more or less?
Yeah. Well, yeah, I don't like answering this, Jasper. So thanks. Maybe you shouldn't have. Maybe you shouldn't have unmuted him. But yeah. So basically, the cognitive training was applied simultaneously with the brain stimulation, and that's to create that synergistic effect. Because the idea is that the tDCS sort of only really operates on neurons that are at the point of sort of firing. So because it's sub-threshold. So tDCS, if you prime that area by getting the participant to perform a task, then you would selectively operate on those neurons that are recruited by the task, and therefore you boost the effectiveness of the task. And in this case, that's what we hope with cognitive training. In terms of the milliamp, so it's, yeah, I was being unfair. Now, I do like answering this question because, for one thing, we don't know what the most optimal dose is. There's very little dosage guidance of what to apply in adults, let alone in children. And most of the current intensities are informed by the adult literature. And that's a problem because, computational models have shown, this is not true for all, but they have shown that whatever you stimulate in the adult, you get double the effect in children. And makes sense because children have smaller skulls, they have more CS fluid, and you can even invert that, standard finding, or I say standard, but the famous finding of anodal excite, cathodal inhibit when you stimulate the motor cortex. So I chose 1 milliamp because that was the smallest that my team were willing to go, and we could have gone higher, but that will cause issues with skin irritation, as well as I was unsure exactly what we were doing to the brain of the children. Since then, there's been lots of more work looking at titrating the dose, going below 1 milliamp. Caroline Breitling has looked at 0.25 milliamps and 0.5 milliamps. But it's not really moving the dial. The work isn't, there still needs to be a lot more done to try and find what the optimal dose is. And Nick Davis is particularly good at drawing caution on stimulating the brains of kids. So there's a question by Arthur. So I've answered that one. Hopefully, the first part, Arthur, of your question is answered. So I believe most studies studying cognition have focused on the DLP-FC. Why target the right FC instead? Any thoughts about the difference between the areas? I hopefully made that point earlier in the talk, but basically there's far more evidence, about 2 decades of evidence, showing that the right IFC is dysfunctional in children with ADHD. The reason why most people target the dorsolateral prefrontal cortex is because everybody targets the dorsolateral prefrontal cortex. For some reason, all our executive functions are found in the dorsolateral prefrontal cortex if you read the literature. It's important, but for some reason, tDCS people are not very imaginative, and they don't think that maybe another area would be better. So that's why, and a lot of the people in tDCS have come from, targeting healthy controls where the dorsolateral prefrontal cortex is the main site. There's one here, another one. So I don't know who's saying another one. It's DJ Khaled. No, Samantha.
Yeah.
Another one. With a sample size of 50, were you able to look at potential differences in responders? The hypothesis that some people respond. Yeah, so I'm a little bit skeptical about looking for responders and non-responders, because it's a great way to find an effect. It's a great way to find a false positive. So if you look at our meta-analyses and subsequent meta-analyses, you compile all of the data together and you get sample sizes of, say, 100 or 200 subjects, and you get effect sizes of, say, 0.2, Cohen's d, which is very small. It's probably not even that. It's probably like 0.1, 0.2 if you're lucky. So you know, at the time we thought we were powered enough because it was the largest of its time, but it probably wasn't powerful enough to find a clinically meaningful effect. So to further break the sample down to seek responders and non-responders could potentially, you know, inflate the risk of false positive. A short answer is that normally you look for responders, non-responders when you see an effect at the group level. And we didn't, so we didn't bother going down that route. So hopefully, Samantha, that's an okay answer. So has research shown similar effects in adults with ADHD, or is it not as significant since you said the effects of stimulation are doubled? So there's comparatively fewer studies in adults with ADHD compared to children with ADHD. When I say that the effects are double, what I mean is that the neurophysiological effects. So the stimulation intensity at the brain is often higher in children than in adults with the same intensity. The effects like cognitive or behavioral, I don't know. So it's not the case that you get, you know, it's double the intensity, you get double even bigger effect. And in fact, I think it's kind of clear now that the effect of tDCS is very non-linear. So, you know, the more current doesn't mean to more effect or bigger effect. You're nodding along there, support. But that's generally shown, isn't it?
Yeah, and I think it would be provocative of us to say to essentially turn the dial up. If you're not seeing an effect, to turn the dial up it'd be A, provocative, and B, quite a crude way of you know, applying that theory.